in this case, I would now want to start by inviting our panelists on the stage. To begin with, I invite Dr. Upendra Kaul, who's the Chairman for Cardiology and Dean for Academics and Research at the Batra Hospital and Medical Research Institute. I will invite you, so please join in, sir. Ladies and gentlemen, continue your thunderous applause as I also welcome Dr. K. Madan Gopal, Advisor and Head for Public Health Administration, NHSRC, Government of India. I'll invite you, sir, to please join us. I would continue by inviting Dr. Anil Saxena, Director for Cardiac Pacing and Electrophysiology for Fortis Escorts Heart Institute. May I please invite Dr. Professor Narendra Nath Khanna, Founder and Chairman for Asia Pacific Vascular Society and Senior Consultant at the Indraprasth Apollo Hospital. And let me also invite Dr. Ram Khandelwal, CEO and Founder for Heart Health India Foundation, to please join us as well. Now, this session we would wish to start by inviting Dr. Kaul. Dr. Kaul, if you can join us for your opening remarks before we set the tone and get into the panel, which will be later moderated by Dr. Madan Gopal.
Well, good afternoon, friends. We are going to talk about a condition which is very often not recognized and or under-recognized, and is very important. So this is called hypertrophic cardiomyopathy. Basically, hypertrophy means when the muscle is thicker than the normal thickness. Cardiomyopathy means we don't know the cause of it. It's not because of high blood pressure. It's not because of any valve disease. But it is, kind of, we don't understand why it is there. Now, this is the picture. On the left side, you see a normal heart. And as you can see, do I have a pointer? No. Pointer? Yeah. So you can see the normal heart, right ventricle and the left ventricle. Obviously, on the left side is the left ventricle. The septum is dividing the two, and as you can see, the septum is less thick than the lateral wall, than the left ventricle. But on the right side, and then you see the histology, that is the section under the microscope of the same muscle, and you see this is the normal muscle texture. Many of you may not understand, but you can see that there is a nucleus. Anybody who has gone through biology classes would know there's a nucleus, and then is surrounded by a homogeneous kind of a red muscle. Then on the right side is hypertrophic cardiomyopathy, heart, where you can see the thickness of the muscle of both the septum, which is dividing, as well as the lateral wall is much thicker than normal. And in fact, the septum is thicker than the lateral wall. It's also called asymmetrical septal hypertrophy. That means it's not symmetrical, septum is thicker. And if you see the histology just below it, you would see totally bizarre kind of a muscle. Disarray, what we call. Total disarray in the muscle fibers. They're not like on the left side, smooth, well-defined, but you can see so many fibers there, and they're all grossly hypertrophied muscle, thicker. Now, it is one of the most common cardiomyopathies. Cardiomyopathy means when the heart muscle is diseased. And this is one of the most common cardiomyopathies, but very often remains unrecognized. That is the reason I think this has been given as a special topic for you. You're not doctors, maybe some of you are going to become doctors later. But this is to be recognized that it is expected, or it is estimated that 1 in 200 to 1 in 500 people roaming around on the streets has hypertrophic cardiomyopathy. That means 80 to 90% of the people with this problem remain undiagnosed. And this is further divided into two types. One is obstructive hypertrophic cardiomyopathy. That means the muscle is thick, it is also producing an obstruction. Obstruction at the level from where the blood goes into the blood tube, the aorta. So the pressure in the ventricle is higher than in the aorta. Normally it's the same. If your cuff blood pressure is 120, the pressure in the left ventricle is also 120. But here what happens, the ventricular pressure is much higher than the pressure beyond it. And half of the obstructive cardiomyopathies have, half of the cardiomyopathies of hypertrophy have obstruction. And the pressure gradient is 30 millimeters or more than 30. And I already told you that the ventricular septal thickness is much more than the peripheral wall. And with that, you see the capacity of the ventricle is reduced. It is so hypertrophied that it encroaches upon the volume of the left ventricle. The cavity size becomes low. The other variety, which is not so common, is called non-obstructive hypertrophic cardiomyopathy, where the wall thickness is there, but there is no gradient, there is no pressure difference. Now, what is the problem in this? On the left side, you see is the normal muscle. And muscle, when it contracts, there is always actin-myosin bridging. As you can see on the left, many of these actin-myosin bridges are sleeping. They are not touching from septum to the wall. They are just quiescent, 40 to 50% of them. And that is the normal contraction. But what happens in hypertrophic cardiomyopathy, these sarcomeres, that is the fibers which are joining actin and myosin, you can see that many of them which were sleeping are also awake, and they are connecting the muscles, the septum with the posterior wall, and 15 to 20% are only sleeping, others are all active. What happens because of that? The ventricle starts contracting very powerfully, it relaxes very slowly, and the cardiac tissue becomes stiff. It becomes very stiff, and later this is going to become fibrosis. That means it's going to become hard, and these muscle fibers are replaced by fibrous tissue, which is hard. Now, very often this runs in families. This is very important to understand, that if you suspect a person to have hypertrophic cardiomyopathy and it is diagnosed, it's very important to screen the family, because many such families will have totally asymptomatic, no symptoms at all, but have hypertrophic cardiomyopathy if you get an echo done. So it is what is called as an autosomal dominant inheritance. If it is there, it passes on to the progeny much more frequently than you expected. Now, it's a chronic progressive disease. It may be totally asymptomatic today, but over a period of time, it becomes more and more apparent because the person starts getting symptoms like shortness of breath or, giddiness or sometimes syncope. So it changes the heart structure, and as you can see on the right once again is the normal heart, and then hypertrophic cardiomyopathy with left ventricular hypertrophy. It also sometimes affects the mitral valve. The valve which separates the atrium from the ventricle on the left side is the mitral valve. So it affects that and it starts leaking. And I already told you the cells of the muscle change. The muscle becomes totally disorganized, or it's called as disarray. 20 to 40% of these patients can get into heart failure, and this is based upon large data of 3 trials. Then arrhythmias, irregularities of heartbeats are common in them. If you do a 24 hours monitoring in them, you put on, many of you must be knowing what is a Holter monitor. You put in a monitor which goes on recording your ECG for 24 hours. You will find 5 to 35% of them you will find abnormal beats. And one of the important arrhythmias is atrial fibrillation, in which the atrium, the upper portion of the heart, becomes totally chaotic in contraction, and that leads to a lot of palpitations, and that can also lead to a clot formation in the left atrium and a stroke eventually. And some of them develop even more serious arrhythmias, which can lead to death. Ventricular tachycardia. It may start as non-sustained ventricular tachycardia, 5 or 6 beats of irregularity, and then stops. But then if it continues like that, then the cardiac contraction becomes ineffective and patient can fall down because the output from the heart is reduced. And then stroke can happen. 4 to 10% of the persons in some retrospective studies have shown that they developed a paralytic attack. Although sudden cardiac death is uncommon in it, less than 1% of them develop sudden cardiac death, but this has been attributed to be a very important cause of the patients with hypertrophic cardiomyopathy, and it is 3 to 4 times more than general population. So that's very important to understand, that you should not scare the person, but at the same time, you know, this particular person runs at a higher risk of dying suddenly. And that usually happens in younger patients with hypertrophic cardiomyopathy. They have shortness of breath as a common symptom, lightheadedness. It runs in the families. And if you listen to their heart, the murmurs are there and they change with postures. You know, in a squatting position, is more prominent. In a standing position, they become less prominent. That is because of the filling of the heart becomes, you know, different in these two. When the ventricle is distended, a lot of blood in it, the obstruction or the obstruction reduces, and when the ventricle is, you know, reduced in volume, the murmur increases. ECG is very frequently abnormal, although a normal ECG does not rule it out, but very often an ECG is abnormal. So if you see an ECG of a person which is abnormal, and in fact these days on the ECG graph only it's written normal graph, abnormal graph. If it is abnormal graph, this condition should be kept in mind. Does he have hypertrophic cardiomyopathy? And then the diagnosis actually is clinched by doing an investigation called echocardiography, ultrasound of the heart, which will clearly show the ventricular size, the chambers. And then I already told you about the symptoms. And signs, ECG, nearly always abnormal. And then sometimes we do provocative measures to produce this gradient. So evaluation of this gradient, you ask the person to perform Valsalva maneuver, something like, you breathe against a closed glottis, or make the patient sit down, squat, ask him to stand, and then you do the echo again, and then you see the gradient. So these provocative tests, we're not going into the details, but they can unmask the obstructions. And it is amenable to treatment. Beta blockers, which are very commonly used drugs like propranolol, metoprolol, are very good drugs for them. They're easily available. There are some people who cannot tolerate them, in that the heart rate lowering calcium blockers like, verapamil, known as isoptin or diltiazem. If the patient cannot tolerate beta blockers, can be given. And then there's a drug called diisopyramide, Norpace, which again is non-specific, but it reduces the contraction of the heart. Anything which reduces the contraction of the heart improves the patient. And then there are some patients who continue to have symptoms. In that, there are some procedures. You inject some alcohol into the artery supplying the septum and make a small localized heart attack in that region. The power with which the ventricle contracts reduces. And then surgery is one of the things. You dissect out the muscle. And then there's a drug which has recently been launched in the Indian market also, I think in the last few weeks only, called mavacamten, which acts against and acts upon the actin-myosin coupling, which I told you is abnormal. It makes it quiescent, and the actin-myosin cross-bridging is reduced. The heightened contractility is reduced, relaxation becomes better, energy consumption of the heart reduces, and the wall stress reduces. So there are some guidelines for the treatment. You see, first of all, you diagnose the condition. If you have diagnosed the condition, then whether the patient has symptoms or not, you start them on beta blockers, which you already mentioned, or calcium blockers. And if the patient's symptoms still persist, then you can give them drugs like diisopyramide or subject them to alcohol ablation. Or now that this new drug, mavacamten, is available, you give that drug. And these are the guidelines both from European side and the American side. So what are the key points? Just to summarize what I talked about, and we'll be discussing it briefly in the panel. It's a complex, heterogeneous disorder, not explained by abnormal loading conditions. It's not because of high blood pressure, it's not because of valve disease, like aortic valve disease, yet the muscle is thick. Approximately 3/4 of them have obstruction, which is subaortic muscular obstruction. And this obstruction, if it is not there, can be provoked by some maneuvers. The ejection fraction, the power of the contraction is very high, and they have got normally we say 55, 60 is normal. They have usually 75, 80% ejection fraction because his heart is contracting very powerfully. Patient may be symptomatic or asymptomatic. Symptomatic patients can have all kinds of symptoms: heart failure, angina, walking. He cannot walk because he gets short of breath, and then extreme sudden cardiac death can happen. Echocardiography, cardiac imaging is very important. It diagnoses it, like echocardiography, or you must have heard the investigation MRI. They're all gold standard tests to pick it up. The prognosis is generally improved by proven therapies, which I already mentioned, maybe repeated many times: beta blockers, calcium channel blockers, cardiac myosin inhibitors like mavacamten. And the very high-risk patients who have got a heart muscle which is very thick, more than 30 millimeters, normally, as I told you, 1.3, 1.5, but 30 millimeters, 40 millimeters, young persons, they are very prone to sudden cardiac death, and they can be given defibrillators, like a pacemaker, a defibrillator implanted there, and in case this happens, it's life-saving. It gives a shock and the person is revived. Thank you very much.
Thank you, Dr. Bansal. So, over to you, sir.
Okay, thank you. After hearing Dr. Kaul about all the signs and symptoms, I was just wondering, because as I was discussing this topic with my son, who is also a doctor, he was saying that the most of the things which now sudden deaths which are being attributed, we don't know for what cause it is been attributed. One of the underlying cause could be this SCN. So that's the kind of thought process which is going on in the young adults. So we have been all attributing this, some of the causes attributed to this to SCN. Post-COVID, we have been attributing to that, but that kind of scenario is there. But most of the time, as a public health person, we often find that it's undiagnosed. If you talk about the stats and other things, we have a prevalence of around 2 to around 7 million cases in India. That's an estimate based on the global standards. But are we able to capture all these things? The age prevalence, if you talk about, it can occur in every age, but by the time the person reaches 40, then only we are able to find out the person is having SCN or not. So that kind of delay is there, diagnostic gap is there. So how we can address this diagnostic gap? And as we discuss, as we have set the context for the discussion, I will be just quickly going to Dr. Anil Saxena, because it is all related to what Dr. Kaul has presented. That means what are the early signs of hypertrophic cardiomyopathy that doctors and the patients often overlook? Because I just cite an example. Common problem is hypothyroidism. It's often underdiagnosed because if the patient is not knowing, if the doctor is not knowing, he's not fully aware, he's not conscious about that, he often misses it.
Very true. I think it's a very important question, and the answer lies in the fact that not many physicians have a high index of suspicion for HCM when the patient, and what we see is I'm an electrophysiologist, we get a lot of referrals for HCM, and what we have seen is that the main reason for referral in India is when somebody has an abnormal ECG, which is detected on routine examination, preoperative checkup or insurance checkup, and then patient is referred for echocardiography, and there it is detected. That is one common mode of referral. The other way it is detected is when the patient becomes very symptomatic. So late referrals and late diagnosis is quite common in our country in HCM. The Third could be a patient who is diagnosed because of family screening of index case. Now that unfortunately is not very prevalent in India, and in the Western cohort a lot of patients are diagnosed early because of family screening, but we have this problem. Another issue is that the symptoms are often misattributed to other things, like somebody may have mild breathlessness on exertion or fatigue or some syncope, and we see a lot of patients getting their symptoms misattributed to other conditions and like obesity or some other problem. And often patients with syncope, they have their neurological investigations done like MRI and CT scan and not looked at the cardiac. Even our echocardiographers sometimes they're more focused on ejection fraction because everybody is busy and they do 50 studies in a day, so they're more focused on ejection fraction, valvular abnormalities, and they often miss out on subtle abnormalities which may be present in some cases, like mild apical hypertrophy or concentric forms are often missed out. Some patients may have only LA dilatation. So all these are reasons why sometimes it gets missed.
Okay, thank you, Dr. Saxena, because one of the important things, unless you are having a higher degree of suspicion, you often tend to ignore all this kind of condition, and you have rightly echoed on that. I will come to Dr. Khanna. So what role can multidisciplinary approach can play in improving early recognition in this condition?
So, once we have these patients of hypertrophic cardiomyopathy, it's very important that we sort of diagnose them, improve the diagnosis. And for that, as Dr. Saxena and Dr. Kaul has said, an echocardiography actually clinches the diagnosis, especially if you are suspecting this or if there is a history of sudden death in the family and you have an abnormal ECG and you have left ventricular hypertrophy with a lot of raised ejection fraction. Now, once we diagnose this, there are some practical, then we need to see whether it's obstructive or non-obstructive. If you have a resting gradient, the diagnosis is almost confirmed. If not, that we need to induce it. And this can be done by simple squatting to standing testing, or it can be done by a Valsalva maneuver. Or if not, then you have to provoke with either low-dose dobutamine or maybe an exercise testing. And sometimes when we do this, there is an issue that you should only do it if the operator is trained to do a dobutamine or a stress echo in HOCM, and also if you have an emergency resuscitation facility. Now, apart from this, there is a multidisciplinary diagnostic requirement which is there. We need to not only check this, we also need to have a good imaging in terms of MRI. Where we actually look at the myocardium, and we must also have a genetist in place who can actually diagnose the exact genetic abnormality and actually do a family counseling and look at the genetic disorders in the family to look at or screen the people in the family who have this sort of a disease. Maybe they are asymptomatic, and also look if there has been a history of sudden death in the family, and to screen these patients and actually follow these individuals over a period of time. So in general, and we also need, if suppose we do, if you have arrhythmias, which many of these patients, we subject them to extended loop recordings or Holter. And if you have arrhythmias, especially two of them are common, atrial fibrillation and ventricular tachycardias or short episodes of VT or VF. In these sort of situations, it's very important to have electrophysiologist in the entire management, because you can actually prevent sudden death in these patients. You can prevent stroke. You can give them timely defibrillators whenever required. So it's a multidisciplinary team, right from the diagnosis to screening and the treatment and follow-up, and that's what is required in this sort of a disease.
Thank you, Dr. Khanna. And one of the important things which you have highlighted, the multidisciplinary team approach. The second thing, Dr. Saxena, you have mentioned about the early signs of this HCM. But one of the important challenges still lies is that how to create awareness among the health providers. That means how because they are aware about the multidisciplinary team which are available. They are aware about the early signs and symptoms, but how to raise awareness about the health professionals. Dr. Kaul.
I think meetings like this are one of the very important forums to make people aware. And, doctors are aware of it, but at the same time, when they're in their chambers, somehow, these conditions are forgotten. So from time to time, anything unexplained which it comes, I think this thing should be kept in mind. And as I told you, an abnormal ECG when you see, it should never be disregarded as, well, this happens in young females, chodo, ye to hota rehta hai. No, try to find it out, take it seriously, and echocardiography is widely available. So echocardiography should be promoted in such a persons. And artificial intelligence can go into a big way in this, Any ECG abnormal, you put it, do an artificial intelligence, it will compare it with thousands or millions of such ECGs and will pick it up. This looks like HCM. So I think the future is bright, and the way we are going, screening has become easier, but the most important thing is the suspicion. If you don't suspect a thing, you won't see it.
Okay, one of the important things, because I remember my days when I was doing my internal medicine residency. So I was there for 1 year. Because of other reasons, I discontinued that. One of the important things for our professor, he was Dr. N.P. Mishra. So he used to say that to try to see the normal things. Make a habit of seeing all the normal signs. Don't miss the normal things. Immediately, the moment you are used to seeing normal things, even a small abnormal things, you are able to pick it up. That means a higher degree of suspicion is coming. I will come to...
Don't brush aside an abnormality.
Yes. So I will just come to Dr. Ram Khandelwal. Since HCM is a common yet often underdiagnosed disease, what initiative you suggest to undertake as a patient advocacy health foundation to increase public awareness? Before I give my comments, because I am also a part of the panelists, but I was given the responsibility to moderate it also. I will give my comments afterwards. Please.
So, I'll start by first telling that I'm not a doctor. I'm a patient advocate.
I'm just saying because when we are working with the ministry, we usually say that the doctor secretary also we call our doctor because they are dealing with doctors. So we always, as a flow of talk, we usually name them as doctors. That's all. So don't take it that you have become doctor. But since you are working among the doctors, half of the doctors and half of the knowledge you are already having. So don't take it that way.
So I'll present the patient perspective. Since I'm a heart patient myself and I represent a community of heart patients. Let me first make a confession here. I was 33 when I had a heart attack, and the first symptoms which I had before a few months which presented, tiredness, dizziness, maybe feeling headaches and many other things. And it happens with a lot of us. But we don't take them seriously. And that's exactly the problem that we see in HCM patients. We confuse them with something else. We might have breathlessness, we might have dizziness, we might have tiredness, we might faint, but we will think that it's something which is very usual, maybe sometimes with acidity, with fatigue and other things, and we don't get checked a lot of times. I think that's where a level of seriousness is required, a level of awareness is required, that how we don't take breathlessness as normal. Breathlessness is not just breathlessness. It's a symptom of something serious, which could be HCM. A tiredness or a fatigue is not something usual. So we need to start thinking that it could be cardiomyopathy. And I think that's where the change begins, and that's where we need to start looking at that how we can early on identify. Because a lot of HCM cases which are symptomatic can be diagnosed early, but they are not diagnosed. It's hardly 5% of the cases globally which get diagnosed. So if we start early, if we do checkup early, and if we screen early, we can actually avoid a lot of fatalities. And in many cases where the symptoms are asymptomatic, the first symptom is people will collapse. So before that happens, and these are young athletes, young students, before that happens, if we are able to reach out to them, because incidence is not small, 1 in 250, That means almost all of us sitting here today, there might be a one HCM patient in this room. But because they have not been tested, we don't know. And I think that's where we need to bring the change.
Khandelwalji, you have raised a very important observation because we are trying to raise awareness among the doctors. But side by side, the general public should also be made aware that they should not be neglecting even a small episode of shortness of breath that needs to be investigated properly rather than relying on the peer groups and the homemade remedies and other things, because that add on to the problem. Because anything which is abnormal that needs to be sought an expert advice. That's the quite message which you are already echoing and other things. Besides that, I will just share that the role of the genetic testing, because we do have some program. The Department of this Nidan program is there, where we are trying to create Nidan centers apart from linking it with the referral centers, so that in a hub and spoke model we can do genetic counseling and genetic testing. But one of the challenges which we are facing in the country right now is to having a trained genetic counselor as well as facilities for doing genetic screening, because this is very high-end genetic sequencing is very high-end diagnostic measure. But if we are able to do a proper screening, which we are trying to invest through our non-communicable disease program, where we are doing genetic screening. You have seen the sickle cell screening also, now genetic element has been added, and Center for Excellences are also coming up. But till the time that comes up, we have to see that how people are made aware and how we can build the capacities of our providers and make them aware so that they don't miss out the slightest number of cases as well. So with this, I think we will go to the next segment. I think the next segment is about the patient journey, the challenges. So I will be starting with Dr. Anil Saxena again with you, sir. So why do patients experience delays in diagnosis even when symptoms are present, and how can clinicians address this? Because already there would be some repetitions, because last session also we have touched upon this aspect. But see that give some example that how they can be reduced. The time to diagnosis and the treatment that can be reduced with some examples.
Right. So it's a very important question, and as Professor Kaul initially mentioned, that the symptoms of HCM are very diverse and very non-specific. So somebody may have breathlessness, chest discomfort, vague discomfort. Somebody may have pre-syncope, syncope. Patient may have atrial fibrillation, or even they may present first time with a stroke because of atrial fibrillation, which is because of HCM. So we have a very diverse presentation. And the key is to have a high index of suspicion, as we mentioned earlier, and training of the healthcare professionals. Another reason is that the high quality imaging techniques, forget genetic, even high quality imaging techniques like MRI and echo, they are largely focused in big cities. So we don't have these facilities existing at a certain quality level in B-type or C-type cities, semi-urban or rural areas. And that is where a lot of patients get missed out. So there is a need to educate doctors and even sonographers, echocardiographers about the HCM and how they can pick the disease early. And then, as you mentioned, in the hub-spoke model, we can refer some of these patients for genome studies and all.
Okay, thank you. Professor Kaul, so I think the same question in a different format. What structured hospital practices can help reduce the gap between the symptoms and the formal diagnosis?
You see, if you go to any echo lab and look at their record of the last 1 month, you're going to pick up some things, Patient has come from general ward for a clearance for hernia surgery. You do an echo and there is LVH. Arey, theek hai yaar, kuch nahi hai. Those are the patients, you pick up there. So I think from the hospital records, you have the addresses, you call them back. And then if you're systematically looking for these people, out of 100 you might find 5 or 6 hypertrophic cardiomyopathies, and every case picked is very important, because you pick up a case, do a family screening, and there you pick up more. And then sometimes, unrelated, you ask, yes, my aunt died suddenly when she was, had gone somewhere. See, you pick up. So I think that is how one of the ways. Once again, it comes to suspicion, which all of us have been again and again saying, you have to suspect it. Whenever you are not able to make 2 into 2, 4, ये क्या बात है भाई? ये HCM तो नहीं है. and seen the prevalence 1 in 250, as Ram said, 1 out of them is HCM. Who? We don't know. So suspect, and then don't stop after diagnosing it. This looks like, send the person to a higher center for evaluation, and that's how you will
That
pick
means
up.
it comes to our, way back to our clinical practice, where a lot of emphasis was given on taking history. And that aspect is now missing, because we are all depending on our other support staff who are taking the history, building up the case record, and then when it comes to the doctor, we often neglect this aspect of family history. That means family history is very important. That means if somebody is having family history of SCN, I think that will be at least address part of the issues. Then Professor Khanna, the same thing. So what are the main challenges after diagnosis, after managing this symptomatic patient after diagnosis?
So, if you look at the challenges first, the first challenge is the awareness and the diagnosis. That we have already discussed. The second challenge is, when you have a patient, how do you treat these patients? There is a problem at the awareness level among the physicians as well. People would start them on beta blockers or maybe calcium channel blockers, but the dose titration is not done properly. A lot of physicians would not, or the echocardiographers would not, know how to actually de-escalate or stop beta blockers before provocative testing. So that's one challenge. On the patient's perspective, the other challenges are, some of them are asymptomatic. They would just leave the drug, not understanding that there is a risk of sudden death. They would leave the drug because of side effects, especially young people who are on beta blockers may have some sexual dysfunction, erectile dysfunction, they leave the drug. And then many physicians do not know, how to, escalate or how to add disoparamide and the newer drugs like mevacamten. So these are different problems and challenges. Somebody is just going to put them on beta blocker and they just follow it up very casually. They don't do the Holter monitoring. They don't involve the electrophysiologist. They would not look for the risk of sudden cardiac death in these patients. They would actually not give them proper medication or ICD when it's required. And as Dr. Kaul said, if you go retrospective on the history, you may find incidences of sudden cardiac death, and they are often missed, and these patients also lose life. And then again, when to escalate to the next level of drug, mevacamten and all, which are very specific drugs. Again, this is a challenge in our day-to-day treatments, some because of affordability, many a times because of lack of knowledge among the physicians. And we don't have dedicated, HCM clinics or cardiomyopathy clinics. If you have a dedicated clinic in a hospital model or a tertiary model, actually you will then be very careful about systems of, on checklists, and be very sure that the patient is not missing out on any form of specific treatment and workup. So this is the most important thing. And of course, affordability in our Indian setting is important, because you are from the government side. You know that this is required, but because the patient is not covered by an insurance or not covered by a government scheme, some patient may still not get costly drugs or ICDs when this is required.
Okay, thank you. You echo the same concern which at working with the government or the public sector, which we have. We are having a very operational national program for prevention of non-communicable. That is there. The objective is to reduce mortality due to this non-communicable disease. We do have a screening pattern. That means, but the challenge is that we cater to only 60% of OPD and around 40% of specialist care. 60% goes in the private sector, and equal number goes to the private sector for this. We do have a screening program wherein we are targeting all adults above 30 years for diabetes, hypertension, and through the CBAC form, community-based assessment form checklist, we are trying to screen the population for that. That's one thing which is there. It's still evolving, and I think coming days you'll be hearing more. But a similar kind of program we need to have for the private sector as well. Because in the government sector, we are catering to that. We do have a scheme which is going, evolving, maturing. We would be able to flag and say that this person is abnormal. At least that kind of screening is there. The person is abnormal, normal. But what kind of further investigation, other thing has to happen, that we have to connect to the hubs or the district hospital or the medical colleges, and that would be had.
In fact, if I'd like to add here, most of the work on hypertrophic cardiomyopathy has been done in the world in one institution, that is National Institute of Health, Bethesda, Maryland. All the patients of hypertrophic cardiomyopathy of North America, United States, are registered there. Barry Maron, which is a very big name in this, is the chief of that program. And the surgery for HCM is a very tricky surgery. Every cardiac surgeon cannot do it. So all the surgeries of HCM referred there. So I don't say that, we should send them there. We should have centers, 3 or 4 centers in the country where HCM patients should be registered, and there should be some, important doctors, cardiologists who are interested in this field, handling them, and then do surveys and other things, because it's a very important disease. Unrecognized, underdiagnosed, poorly treated, beta blockers, 25 milligrams of metoprolol given twice a day, jabai. That is not,
Yeah,
you,
one of the challenges
you require 400
Yes.
milligrams.
Yes, you have just put a very, your hands on the pulse. Because one of the challenges and the system which we are having is having CTVS surgeons now. Because the super specialty seats and other things, we have to see that how we motivate people to join. Because very intensive, very challenging, require a lot of passion. Because cardiac surgeries for myopathies, I think it takes a lot of time, a lot of passion. Because without a passion, you can't be having CTVS surgeons. So that's a challenge which we are having. Khandelwalji, I will come to your journey because you have traversed as a patient. And now the challenge is that how can the patient education, how we can have a patient who has experienced this, he can act as a peer educator for the others, so that the catastrophe which you had, the agony which you had, that can be minimized to the other patient. I slightly modified the question, don't worry, but you can answer it.
So let me just ask a simple question. How many of us know from Ramayana who's wife of Ram? How many of you know? Just raise your hands. Yeah, no scoring, no scoring. Just raise your hand. Who's the wife of Ram? If you know it. Okay, I can see at least 25%, 30% hands up. What is the distance between sun and earth? Anybody who knows that without looking at Google? Okay. So, 2 numbers or maybe 2 facts, but the difference here is what we remember and what we don't remember. We think of education as we will teach something by giving a flyer, sending an information, giving a definition, writing few bullet points, and people internalizing it. Not true. It's not patient education, it's patient learning. What they are learning and how they are learning. So if we make a difference in the learning process of patients, if we make it more relatable to them, if we make it more understandable to them, then patients can relate better, they can identify better, and they can present early in their course of action. The main challenge that we see here is we are not using patient storytelling as an instrument. And that is the most effective instrument we have seen. When we hear Ramayana, we remember that Ramayana for decades. We don't forget what happened in the Ramayana story. When we hear a patient saying, I collapsed one day and I was having these symptoms, we'll remember that for 10 years. Because we relate to it. And that's what real storytelling makes a difference. When we pick up people from real life who have experienced it, who have told other people that these are the signs and symptoms which I was facing, but I didn't realize. Or this is the mistake which I made, that's why I didn't went to the doctor for next 5 years or 10 years. Then people know, oh, I have to be watchful. And that's exactly what patient education should start focusing on. That making these experiences more relatable, making these experiences more accessible to people so that people can know what real life experiences are and not just numbers on a pamphlet or a presentation.
As a follow-up question for the next segment also, so how can you help in organizing and making patient support groups and network?
So there are two parts to it. One is intake process, that how do patients come into a community? Right now in our country, we do have mechanisms. So for example, if we talk about national health policy or the NPNCDS policy, operational guidelines, it says patient support groups should be there. You go on the ground, nothing exists.
You have to see that how you can help in creating
Now,
that
how it
support
can
group.
be helped, just last week when I was in Singapore, I was talking to NUHS. What they have done, the government hospitals have a linkage with patient support groups. So the referrals are happening that every patient which is diagnosed is actually referred to a patient support group, which is currently missing in our country. Once the patient comes in, then their experiential journey starts. So for example, at our foundation, we do something called as storytelling circles. What is storytelling circles? We get patients in the room and we let them talk to each other in a structured way. How it helps understand the journey from diagnosis to treatment to recovery, and people learn from each other and people know what I can miss or maybe what is normal, what is not normal, when is the emergency, what are the false alarms, what are the practical ways of doing things. And I think that's how we kind of, one part is building these communities. So if every hospital could have a referral mechanism that post-discharge, it's not just treatment, post-discharge journey has to be established. Because all these diseases which we are talking about under cardiovascular, including HCM, these are chronic diseases, these are lifelong diseases. Once you have had it, you have to live with it for next 20, 30, 50, 40 years.
Okay, thank you. That's quite elaborate because that makes the job for the Dr. Saxena and Dr. Kaul and Dr. Khanna easy, because the follow-up questions I am going to ask them. Because Professor Saxena, he has mentioned about this. Once diagnosed, what are the challenges in providing treatment and how you are managing the patients?
Yeah, so the main challenges are that we, till very recently, we did not have any specific therapy for HCM. So we were doing a lot of indirect management strategies, like for example, trying to reduce the hemodynamics, change the hemodynamics by giving beta blockers and calcium blockers and disopyramide. And if these were not effective in very severe symptomatic patients, we would try to reduce the size of the muscle by either ablating muscle with alcohol, injecting alcohol so that some of the muscle dies, or surgical approach where some of the muscle is shaved off, thereby reducing obstruction. But these are all not very good therapies, and many patients had complications of surgery, as Professor Kaul mentioned. Very few surgeons can really do it well, and septal reduction therapy have their own complications. So now we have a drug which directly addresses the pathophysiology of the HCM, which is called cardiac myosin inhibitors, and one of the drugs is mavacamten, which has recently been introduced. So it directly addresses the pathophysiology of the hypertrophic cardiomyopathy. That is, as Professor Kaul mentioned, that there is excessive bridging of the actin myosin in the muscle. So it inhibits that, and thereby it can reduce the contractility. It can improve symptoms. It can help the patients avoid septal reduction therapies. So there have been many trials, like Explorer trial was one which focused on clinical parameters, which showed that patients who were given mavacamten, they had better clinical outcomes in terms of symptoms and gradient reduction. And the Valor trial, which showed that the need for septal reduction therapy was significantly reduced in many patients. So as the recognition is improving, the clinical management of HCM is also undergoing a sea change, and we are getting a lot of new therapies available which will help our patients in future. So I think that's a very important development.
Okay, thank you. Because Professor Kaul, once again, because these patients require long-term treatment, how can a doctor ensure that this long-term treatment is being adhered, and the management of complications, other thing associated with this long-term treatment that is being managed?
See, none of the treatments which we have today is a curative treatment for HOCM or HCM. And I've seen the natural history of, in few patients, of HOCM coming from 75%, 80% ejection fraction becoming less, and finally landing up as dilated cardiomyopathy. Yes. Given, CRTDs, I have 2 patients requiring CRTD. So it's basically what I try to mean is that it's a progressive disease. We don't have anything which can reverse it. We can prolong, we can reduce the symptoms. And follow-up is very, very important. The patient, we have patients on 200, 300 milligrams of metoprolol and diazoparamide, 300 milligrams. They come for follow-up. We do an echo gradient, is the same. Because when the patient comes, he's charged. He's in a catecholamine liberating state. Although the patient says he's feeling much better, but there has to be something like an ambulatory monitoring of the pressure gradient, because otherwise it's difficult. So you do provocative tests and other. So follow-up is exceedingly important, and the natural history of it is not very good. And younger patients have poorer, bad natural history.
Yeah, how can we ensure proper follow-up? Because loss to follow-up is quite common.
Patient education, explain to them, spend some time with the patient and the family and tell them that this is a problem. Somebody says, "Arey, tumhara heart to bada acha chal raha hai, 75% chal raha hai, tumhe kya pareshani?" No, this is, an harbinger of a problem. So you need to not allow this.
Because this becomes important in the era of this information explosion, where there are a lot of claims, counter-claims about the other therapies. So in that case,
like mavacamten has come, it has a negative side also, You have to be careful. You can't just give him 5 milligrams of mavacamten of Jao. You have to review him after 1 month. If the ejection fraction starts falling, you have to stop it. You have to go then by 2.5 milligrams. Okay. So it's all a complex game.
Hey,
but we have progressed a lot in the last 20, 30 years. These patients have become much better off, less symptomatic, but disease continues to be progressive.
Okay. So even the risk of sudden cardiac death needs to be reviewed every 6 months, because something may happen in between which will change the risk. So we have to then consider ICD.
We have not shown that mavacamten prevents sudden cardiac death. Yeah. No.
That's why this becomes very important, because we have to generate some evidence, we have to talk about science only.
You start mavacamten, don't give a huge hope to the patient. Tell him that this is a drug, it's going to help you, but you have to be careful, you have to be coming, and doses have to be regulated, and Holter monitoring to be done. What's happening to the patient's arrhythmias? Invariably, a Holter monitor of a HCM patient will show arrhythmias. Small numbers or large numbers, ectopics, NSVT, so frequent.
Okay. Thank you, Professor Kaul, for such an elaborate, at least that the message should be clear. That means the proper follow-up, patient care, patient education, that's a key for a proper follow-up and adherence to the treatment, whatever treatment plan which you are having. Professor Khanna, because one of the important things, it requires multiple specialty, multiple discipline. How we can ensure that timely management happens across all this to the patient?
So again, I'll put the same facts. One, that we have to, if the patient comes to, say, a tertiary care hospital or a good government hospital like AIIMS, it has to be, the patient has to be screened by multiple specialists, especially the cardiologist, electrophysiologist, geneticist. 3 are very important. And then the follow-up is very important, and that can only be done if you have dedicated teams or a system, checklist which is there. Somebody who has got a cardiomyopathy, hypertrophic cardiomyopathy is like, it's a disease like diabetes. It's a disease where you have to live with it throughout your life. It requires regular checkups. It requires future therapies. It requires close monitoring and reassessment of risk and the progression of the disease. And not only this is a different disease, like you sort of, in diabetes, you look for the family. Here, you have to look for family history. You have to do genetic counseling, genetic screening, and pick up patients, not even patients, pick up susceptible individuals who could become patients and who could have sudden cardiac death. And then one of the most important thing in these patients is to give them lifestyle modification advices, allow them what sort of activities to be done and what should be avoided. These are very important things, all deaths which we see in gyms they say it's a sudden heart attack or sudden cardiac arrest. Many of these could also be having, genes which are responsible, or they may be having silent asymptomatic cardiomyopathies. So it's very important that this awareness is created among physicians. There are set protocols and checklists, and it should also be available to the patients at large. And especially as Mr. Ram Khandelwal said, patient story and patient getting, probable families learning through patient experiences is what is going to create this sort of a wave of understanding.
Okay, thank you for, at least you have made my job easier for summarizing all this thing. One of the important thing which is coming is patient awareness, the capacities of our providers, and the multidisciplinary approach with the involvement of the patient network group. But before closing, let me share that what we have been doing, because this long-term treatment is a catastrophe event for a patient. So what we are at the government and what we are doing, we are having Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, though there would be operational challenges with that, but the benefit packages includes the surgeries, the pacing of the heart, the myomectomy and other procedures are there. We have to see that how we popularize it so that the benefit, the rural benefit is being provided to the people. Second part is the Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana, which is there, and the Amrit program is there for the affordable treatment. How we see that, how we leverage, because long-term treatment is required. How we can leverage these schemes which are available so that we can at least help the patient, and from the patient support group also say that these are the scheme how you get connected and make these things. Besides that, in the government sector, we have been able to support the cardiac care units. We see that how we utilize it. It's not that only government can do things. We have to see that how collaboration can happen between the government and the private sector. The facilities which we are creating, in fact, we have critical care blocks also we are creating. See that how these facilities can be leveraged and how a private sector and the government can work in a hub and spoke model. That kind of models can also evolve. Thank you very much, Professor Kaul, Dr. Sapta, everybody. Thank you very much.
Thank you so much, sir, and thank you each and every panelist present here for this insightful discussion. Now, sir, I would just request Dr. Kaul, I would request to please stay back on the stage for a felicitation ceremony. I would request Dr. Madan Gopal to please felicitate our speakers, starting with Dr. Upendra Kaul. Let's have a round of applause for their amazing insights. Dr. Anil Saxena. We can give them a huge round of applause. Dr. Professor Narendranath Khanna. And Mr. Ram Khandelwal. I would request Dr. Naveen Nishchal to please come on stage and felicitate Dr. Gopal for his amazing moderation. Let's capture this moment with a photograph.